number 5, so we can start this morning. So we've gone through the cell wall synthesis inhibitors. So we're going to move from the cell wall onto the inside, and we'll come across the cell membrane. So we'll discuss agents that would interfere with cell membrane functions. The cell membrane inhibitors, if you will, are listed up here from number 1 to number 5 there. Amphotericin B and nystatin are cell function inhibitors, but they are mostly used as antifungal agents. So amphotericin B and nystatin will be discussed under fungus. Gramicidin is mainly used topically and is often used in combination with other agents. For instance, you can have that PNG, polymyxin, neomycin, and gramicidin, PNG, that is used topically. So, and that is a solution of your neosporin, PNG. So basically we'll just deal with the polymyxins. And the polymyxins you can divide into 2. You have polymyxin B and polymyxin E. I wrote them up there. And if we look at the polymyxins, we know that they're true antibiotics, since they are obtained originally from a bacillus, Bacillus polymyxa, and then that's polymyxin B, and polymyxin E is the one that is called colistin, because it's Bacillus colistinus. Sometimes you can see that Bacillus written as Panibacillus. That's another name for that organism. Okay. If we look at the spectrum of the polymyxins, we can see that they would include Acinetobacter, and then Bordetella, Acinetobacter, Bordetella, that would be some. And then we can see some other gram-negative organisms like your Streptobacillus can also be effective against your Pastorella. Pastorella, one of the so-called Ella sisters. And of course, Pseudomonas. that's a main one. What you use it for. That's the primary indication of polymyxins. Infections caused by Pseudomonas. And then, of course, your Klebsiella can also be effective against that. Okay. E. coli and Enterobacter. So essentially it's like capes. The polymyxins are very narrow in terms of their spectrum. As you can see, they're mainly effective against gram-negative organisms. Gram-negative organisms that are bacilli. So gram-negative bacilli, and that are aerobic. So very narrow spectrum. And they will give you a bactericidal effect. Bactericidal effect that is concentration dependent. So concentration dependent bactericidal action. They are essentially effective against all gram-negative bacilli aerobic organisms, but they are not cidal against your Salmonella. They're not very good against Salmonella, and they're not very good against Shigella either. And Proteus species are very resistant to polymyxins. Okay. Providentia species are also resistant. So they don't produce bactericidal effects against your Proteus, your Salmonella, and Shigella, and then Providentia. Okay, so that's in terms of their spectrum. In terms of clinical usage, this is the main organism that they are used for, Pseudomonas. So you always think of the polymyxins as agents of last resort, after you've tried everything else. And that infection also has to be serious for you to use, Aerosporin by itself. Okay. So that's in terms of their coverage. When this agent, Acinetobacter, when it causes nosocomial infections, that is in the hospital, you can see polymyxin B used by itself, because that's usually a serious condition. And you know that that's one of your CAPES organisms that we said that you can use cefixime for. Maxipin. Okay, so, and Bordetella, of course, is the causative agent of whooping cough. Bordetella pertussis. Okay. So, and we've mentioned Pastorella that you can see in bites, you know, like cat bite fever. That can be caused by Pastorella species. Pastorella mortosida. Okay. So, but by and large, you use polymyxin B, you know, aerosporin, when you have a severe Pseudomonas infection. And the see if this one will work. When you use polymyxin B, it has to be after you've tried aminoglycosides, you know, and you've tried a beta-lactam, let's say your penicillins, particularly pen G. So if the organism or the infection is not responding to either penicillin or an aminoglycoside, that's when you think of using aerosporin. And polymyxin B is one of those antibacterials that you can see ordered in units, you know, and we say that 10,000 units of polymyxin B is equivalent to 1 milligram of polymyxin B. Now the route of administration for polymyxin B, because that's the one we're using as the representative agent, polymyxin B. It can be given orally. It can be given IV, can be given IT, and can be given IM, and of course, topically. So the routes of administration that you see used most often are those two, intramuscularly and topically. Okay. And when you give it intramuscularly, you have to give it with a local anesthetic, about a 1% procaine, to reduce pain and tissue destruction. So it is usually administered with a local anesthetic. Okay, and for topically, it's usually administered in combination with other agents. We'll see those in a second. And the usual dosage is about 1.5 to 2.5 milligrams per kilogram per day. All right. So if we look at the mechanism of action, these are like cationic. cationic detergents, that is surface active agents. So basically they react with the lipopolysaccharides. The lipopolysaccharides that are on the surface of the membrane, and also they can react with the other lipid components of the membrane, other lipids on the membrane, like phospholipids that are on the membrane. And by reacting with those, because the membrane will be anionic, so you would have an anion basically reacting with a cation. So, and when that reaction takes place, you will get channels or holes being created on the membrane, and then the internal medium of the bacterium will leak out, and that's why they can cause that bactericidal effect. So you have the anion on the membrane reacting with the cation from that polymyxin, and that reaction on the lipopolysaccharides or on the phospholipids will lead to holes, channels being created on the membrane, and then you get leakage of the internal medium of that bacterium, and that would lead to death. Okay. That's one mechanism, that's one way by which your polymyxins work. Another way is to actually inhibit respiration in the organism. It can inhibit oxidoreductases that the bacterium uses for respiration. You bind to NAD, reduced NAD, that is NADH. That's your reduced NAD, and quinone complex. So NADH quinone complex is what your polymyxin would interact with, and through that it would inhibit this oxidoreductase, and so the respiration of the organism would be impaired. So those are two pathways for the mechanism of action of your polymyxins. And if you look at the half-life of polymyxin, is usually about 6 hours, and excretion is primarily renal, undergo renal excretion. And we look at the indications, one indication is what we have mentioned. If you have bacteremia or urinary tract infections, or UTI that is very serious, or you have meningitis that is caused by Pseudomonas species, very serious infections, and you've tried aminoglycosides or penicillins, they didn't work, then you go to aerosporin or polymyxin. So that's one indication. Another indication is for the management of CRE. Colistin, which is colistimethate, the polymyxin E, is more effective against CRE, carbapenem-resistant enterococcal infections. And that can actually also include your enterobacteriaceae, that is gram-negative aerobic bacilli, which is within the antibacterial spectrum of your polymyxins. So they're very commonly used for the organisms that have resisted your penicillins and aminoglycosides, and you can use them in CRE. But the most often usage of polymyxins that you see is when they're used topically in combination with other agents. And some of them we've discussed before. We talked about PNH before and PAB, with all this P being polymyxins. Okay. And you have one which is PO, that is polymyxin with oxytet, that is oxytetracycline. Stated on the text, number 14. And that you can see under the brand name terramycin ophthalmic. Okay. So that's PO. You can also see your PT or polymyxin trimethoprim, which is polytrim. Polymyxin trimethoprim. And we've talked about all your PNG, PNGH, and PNGH. It. I mentioned before gramicidin, polymyxin, neomycin, gramicidin. PND is maxitrol. So it is used in combination with all those agents for eye conditions, and well, you can see it for ear and eye infections. But here again, you want to reserve it for corneal infections caused by Pseudomonas aeruginosa. If the eye infection is caused by just staph, Staphylococcus, you use the bacitracin containing ones, bacitracin. But if the eye infection is severe, like corneal infection, and Pseudomonas aeruginosa is the causative organism, you want to use your aerosporin or polymyxin B containing product. Okay. The adverse effects that one can see with your polymyxins. There are two major adverse effects with polymyxins. One is neurotoxicity, and the other one is nephrotoxicity. Okay. The nephrotoxicity is usually manifested as things like an elevation in your BUN, blood urea nitrogen. And you may also see azotemia, or you can see casts in the urine, or you can see oliguria. That may be present, and you can see albumin in the urine. Okay. Azotemia simply means elevation of nitrogenous wastes. In other words, you see an increase in creatinine, nitrogenous compounds like that, ammonia and things. When azotemia gets to the level of producing signs and symptoms, okay, that you can actually perceive, that's when you use the term uremia. Okay. So the only difference between uremia and azotemia is the exhibition of signs and symptoms in that patient. So those are the manifestations of the nephrotoxicity of your polymyxins. And that's usually considered major, because if you have azotemia and you have oliguria, which means scanty formation of urine, then you are just one step away from having a renal failure. So it's usually taken seriously. And of course, that would be a major drug-to-drug interaction point for your polymyxins. So it will interact with your aminoglycosides, because all aminoglycosides cause, nephrotoxicity. Drugs like your vancomycin also will cause nephrotoxicity. In terms of the neurotoxicity, the manifestations of the neurotoxicity can be kind of muscle weakness. So you can see weakness and numbness and be observed. You have your perioral paresthesias. Basically, numbness around the mouth, perioral. Okay. Around the mouth, and we can see things like insomnia or and irritability. Irritable, and neuromuscular blockade. Okay. And that neuromuscular blockade may further weaken, cause muscular weakness, and it may lead to paralysis. It may also lead to apnea if it affects the respiratory muscles. So that can also be serious. Of course, some minor ones like your drowsiness, and in some cases dizziness. So all of those can be manifestations of the neurotoxicity. Sometimes the patient will not be balanced, so ataxia may also be a manifestation of the neurotoxicity of your polymyxins. So we'll leave it there. The colistin, which is polymyxin E, that can be administered also orally, and it can be administered topically, and then you have the parenteral routes of administration of your polymyxin E, IV, IM, and IT. So we'll leave the membrane and go on to the cytoplasm of the organism. And what goes on in the cytoplasm is basically protein synthesis. And the antibacterials that affect protein synthesis, that is protein synthesis inhibitors, can be divided broadly into two. maybe we can extend it a little bit and say some miscellaneous agents, the ones that don't quite interact with macrosomal 30 or 50S macrosomal subunits. But by and large, you divide them into those that work at the 30S or those that work at the 50S ribosomal subunits. The ones that work at the 30S are your aminoglycosides and tetracyclines. Basically, every other one works at the 50S ribosomal subunits. And so we can start off with the ones that work at 30S. Another way you could see the aminoglycosides classified will be based on the spectrum of activities. In other words, you can have some that work primarily on gram-positive organisms. And you can have some that work mainly on gram-negatives, and then ones that are so-called broad spectrum. If you use that classification, that is mechanism of action or spectrum of activity, the ones that will work on gram-positives mainly will be your macrolides. Macrolides. This key tech we really should take out. That's telithromycin, and that has now been removed from the market, so we don't need to talk about it. Okay, telithromycin, I have it written somewhere here. Telithromycin number 28. So you can essentially leave that out. It was used for only one thing and one thing only, but anyway, we don't need to mention it anymore. So primarily gram-positives, even your chloromethylanes work primarily there, and put the okay. All right, let's put that. Oxazolidinox. I've listed them up there. Still linezolid and tedizolid, 32 and 33. Those are oxazolidinones, and they work primarily also on 50S. Chloramphenicol is believed to be a broad spectrum agent, so that will be that. Aminoglycosides will work primarily on gram-negatives, and your tetracyclines will be broad. So if you use that classification, that's how they will fall out. So we'll start off with the aminoglycosides. So those will be the 30S inhibitors that we'll be talking about. aminoglycosides. The aminoglycosides are gentamicin, tobramycin, neomycin, amikacin, and paromomycin. So, streptomycin also. Okay. So those are the aminoglycosides, and we'll be looking at gentamicin as a representative agent for the aminoglycosides. So the aminoglycosides have certain things in common. They have certain things in common. Number one, they are very polar compounds. Okay. Because they are amino sugars, in glycosidic linkages with some hexoses. But they are polar compounds. And being very polar, they will have poor GI absorption. Okay. There are only two now, because the other one, kanamycin, has been taken off the market. So there are only two aminoglycosides that you can see used orally. One is neomycin, and the other is paromomycin. Okay, so right there, paromomycin, and then neomycin, numbers 8 and 10. Those are the only two now that you can see used orally. Anytime you use an aminoglycoside orally, it would also be effective against amoeba histolytica. So it would also be helpful in managing amoebiasis. The organism that causes amoebiasis is what? Entamoeba histolytica. That's the causative agent of amoebiasis. And amoebiasis can be just intestinal. It can occur just within the intestines, GI. Or it can be extra-intestinal, which means it occurs outside of the intestines. If it's intestinal, yes, you can use an aminoglycoside. Okay, but this drug, Flagyl, can be used for both intestinal and extra-intestinal amoebiasis. Okay. So, if it's given orally and it's an aminoglycoside, it will be helpful in the management of amoebiasis, and it would also help you to manage PSE. That's portal systemic encephalopathy. And that is commonly referred to as hepatic coma. PSE is sometimes referred to as hepatic coma. And the problem here, or what's really happening, is that you're generating a lot of ammonia that is now being converted to ammonium, NH3 and then NH4. Okay, that ammonia can then travel to the brain and cause dysfunction in the brain. That's why you say encephalopathy. So if an aminoglycoside is administered orally and used orally, it can also be helpful in managing PSE. All right, so we know the polar. Number 3, they all tend to be bactericidal. They're all bactericidal. And they can all produce, to varying degrees, some neuromuscular blockade, and they can also all produce, to varying degrees, autotoxicity and nephrotoxicity. So that's why we said they can interact with your aerosporin. Remember, aerosporin produces those neuromuscular blockade and nephrotoxicity. And they all interact with your 30S ribosomal subunit when they are inhibiting protein synthesis. They can all produce a post-antibiotic effect. So after you have given let's say gentamicin, and you expect its effect to have run through, it continues to actually work on the bacteria. And that discovery has basically helped a lot of patients, because you can just use the dosage that you would have given 3 times a day. You can just give it once, and it will continue to produce this antibacterial effect. Like say gentamicin, if you administer gentamicin IV, normally you would use 80 milligrams, like 3 times a day, you piggyback, but you can actually use the entire dosage together one time, and it will cover the whole day. So post-antibacterial effect is common to them. Cross-allergenicity. If you're allergic to one, you will probably be allergic to the rest of them. And they all tend to go out through the renal system. Renal excretion. And I should add, and that's important, unchanged. Okay. They get excreted unchanged in the urinary tract system. And that is why you have to be conscious of the creatinine clearance when your aminoglycoside is being used. put to the side because sometimes we try to pull drugs together. You should be conscious of the creatinine clearance also when Fetroja is being used. Okay. Aminoglycosides, Fetroja, and Maxipin. Because Maxipin is excreted almost 100% through the renal system. So one has to be conscious of the creatinine clearance in such situations. So these things are common to your aminoglycosides. And we've seen the mechanism of action, we've seen the similarities. We can look at some methods or mechanisms by which bacteria can become resistant to the actions of your aminoglycosides. One way is through mutation. So the bacterium can just change its responsiveness or the responsiveness of that 30S to your drug. So if the aminoglycoside cannot bind or cannot work effectively at that 30S, then the organism will be resistant to its effects. So mutation is usually called point mutation at the 30S ribosomal subunit. So that's one way. Two is for the bacterium to decrease the uptake of the drug. And how would the bacterium do that? By altering its cell wall. So it can change its cell wall or alter its cell wall so that it is not permeable to your drug. And so the bacterium will not be affected. That's the basis of the synergism that you see with your aminoglycosides and the beta-lactams. Aminoglycosides are synergistic with all your beta-lactams, and that's the basis for it. Okay. Or maybe the organism is changing uptake because it is lacking oxygen in the environment. Okay. All aminoglycosides require oxygen in the environment for them to be taken up. So the active uptake of aminoglycosides into a bacterium depends on an active transport process that is oxygen dependent. And if there's no oxygen in the environment, then the aminoglycosides will not be able to get in. And actually we can include that as number 9 as something that is common to all of them. And that is this. And that is the fact that they would not work on anaerobic organisms, because anaerobic environment means no oxygen. So that's why they will not work on anaerobes. Or the way we can put it is that aminoglycosides are universally ineffective against anaerobes. There's a drug there called chloramphenicol, and I put it here. Chloramphenicol is like the opposite of that. Chloramphenicol is universally effective against anaerobes. Aminoglycosides are universally ineffective against anaerobes. So it's like that. And then 3, the resistance can be enzymatic. Okay. There are 3 enzymes or so that are on the surface of the bacterium that can actually break down your drugs, you know. Adenylase is one of them. And then you have acetylase. And that's this thing. And those two are commonly present on the surface of the bacterium. So when your drug comes or tries to get into the organism, the organism can elaborate those. Less often is the phosphorylase. There's an aminoglycoside that is called amikacin. I must have put it here. Number 9, amikacin. Amikacin, number 9, is resistant to those enzymes with the exception of your acetylase. And that's why amikacin is used for nosocomial infections, you know, because you do get a lot of infections in the hospitals where you have to use an aminoglycoside. So for some nosocomial infections that are caused by gram-negative organisms that are aerobic, you might want to use that amikacin because it will not be destroyed by all the enzymes except for just one. That's where we can see resistance. And if we keep in mind then that we're using gentamicin as a representative agent. So gentamicin you can you can administer intramuscularly, okay? And that is the preferred route of administration of all your aminoglycosides when they are given parenterally. They work best when they are administered intramuscularly. Okay. And so you have, let's say, gentamicin. You know its mechanism of action. It will interact with 30S ribosomal subunit to inhibit protein synthesis. That's the mechanism of action. In terms of ADME, route of administration, gentamicin can be administered intramuscularly, and it can also be administered topically, by inhalation. Okay. In terms of its half-life, it is usually about 2 to 3 hours in terms of the half-life, and it is well distributed into the extracellular space, because it does not cross biological membranes very easily. However, it does cross the placenta barrier, so it can cross the placenta barrier and get into the fetus. And that is one reason why you say that aminoglycosides are pregnancy category D, D as in David. In other words, don't use them in a patient who is pregnant because they can cross the placenta barrier and cause some damage there. But in terms of the distribution, your gentamicin can go into the pleural cavity, that is chest, so pleural space, into the peritoneum. Okay. It gets distributed to the peritoneum, it gets distributed to the bile, it also goes into the synovial fluid, and it can also get into the saliva. So it goes into all those places. Biotransformation or metabolism, essentially zero. Gentamicin is not metabolized, so it goes out through the urine mostly unchanged. Okay. So that's metabolism, and then excretion, we've mentioned just renal, and that's why you have to pay attention to creatinine clearance when using your gentamicin. Okay. The adverse effects before we talk about indications. So adverse effects for gentamicin would be those three that we've mentioned: neuromuscular blockade, and for that neuromuscular blockade, you can use calcium salts to reverse the blockade. Okay. And that's one of the other reasons why you don't want to use gentamicin in a pregnant patient or in a small or neonate, because the neuromuscular blockade can lead to that apnea, and which will interfere with the respiration of that patient. Okay. So if you give a calcium salt, or if you give your cholinesterase inhibitors, you can reverse that neuromuscular blockade effect. And the neuromuscular blocking adverse effect is usually worst in neomycin and is least in streptomycin. Okay, so neomycin is the worst offender, and streptomycin is the least offender. Gentamicin and tobramycin will fall in between those two parameters. Okay, so that's one. Other toxicity, the same thing. Neomycin is the worst. Streptomycin is the least bad, if you will. And that ototoxicity can affect hearing. It can also affect balance. For instance, when you look at tobramycin, which is that number 7 there, tobramycin can actually affect both almost equally. That is balance and hearing. You know, can affect both. Gentamicin and streptomycin, those tend to affect balance more than hearing. The problem with the ototoxicity is that you may never recover from it. No matter how long ago you got an aminoglycoside. So it's very long lasting. Whereas your neuromuscular or your nephrotoxicity, once you stop taking that drug, you know, the adverse effect goes away. Okay, and then so nephrotoxicity. So those three, okay, and then number 4, you can be affecting absorption. So malabsorption syndrome. Malabsorption syndrome can be an adverse effect. That is usually seen with neomycin more than any of the aminoglycosides. Neomycin. And you can also see supra-infection manifested as things like pseudomembranous colitis. Okay. And the worst offender there also is neomycin. Neomycin is the one that is most likely to give you pseudomembranous colitis. Peripheral neuritis, and that is most often seen with streptomycin, that peripheral neuritis. And scotoma, which is blind spot. That one is most often seen with streptomycin also. So those are the major adverse effects that one can see with your aminoglycosides. Indications. Well, we're talking about gentamicin. So one, it can be used for the management of burnt tissues, because you want to prevent the colonization of a burnt tissue by gram-negative organisms. You know, so that's why they can be used. I mean, you have silver sulfadiazine, which is most often used for burns on the skin. But gentamicin can be used, and that will be the topical gentamicin that will be used in that situation. Okay. Brucellosis. So you can use it, that's caused by brucella. And you know you have different strains of brucella. Brucella abortus, Brucella menitensis. Brucella suis, that's another one. Brucella canis. Those are different strains of brucella because you get brucellosis mainly from lower animals. You know, if it's the cow or whatever, you know, beef, that's abortus. If it's from goat or sheep, that will be melitensis. And if it's from pig will be suis. If it's from a dog, it will be canis. And if it's from rodents, it will be the nematode. So, okay, yeah. 3 urinary tract infections, of course, caused by a gram-negative organism. Yeah. So you can see. Meningitis, there is a preparation of gentamicin that is specifically meant for that. Let's list them first. So, Mycobacterium avium intracellulare complex. Avium intracellulare. Complex. You can use gentamicin. Sepsis, that is gram-negative sepsis, you can use it for that. Pneumonia, you would not use it in CAP. You don't want to use gentamicin in community-acquired pneumonia because those are usually caused by gram-positive organisms. Okay. But if the pneumonia is caused by gram-negative organism, then you can use it as long as it's not an anaerobe. So you can use it. There are osteoporosis, osteomyelitis. Bone inflammation, yeah, you can use gentamicin. You can also use it for eye infections and ear infections. when caused by gram-negative aerobic bacilli. Okay. And then dernovanosis. That's an STD, you know, the one that we used to call granuloma inguinal, or just GI. Granuloma inguinal. So you can use it in all those situations. Let's see if we can do this. Septopal is a preparation of gentamicin that is basically used for that osteomyelitis. You know, it comes like a wire that has some beads, and those beads will contain gentamicin, and so it will be used that way. That's a gentamicin preparation that is called MyTech. And MyTech is a liposomal preparation of gentamicin. And that liposomal is a liposomal preparation of gentamicin, and that is used for the management of MAC, that number 5. So it's a special preparation that is used for MAC. Okay. Whatever you use gentamicin for, you can also use tobramycin for it. However, their effectiveness is different. Gentamicin is better than tobramycin. Okay. When you are treating infections caused by your Serratia species, but tobramycin will be better than gentamicin when you are treating infections caused by Pseudomonas aeruginosa, or even Providentia, or even your Proteus species. Tobramycin will be better than gentamicin. Okay. And the only other thing that is used that is a little different will be your paromomycin. Paromomycin, well, let's start at the top. That's a preparation of tobramycin that is called Toby. And Toby is most often used for cystic fibrosis, you know, in the cystic fibrosis patient. You of course have Toby combined with other, tobramycin combined with other things. You have Tobradex, which is tobramycin with dexamethasone. You have just the brand name Nebsin, which is like tobramycin that you inject parenterally. And you have Tobrex. Okay, Tobrex is different from Tobradex. So let's see. Tobrex is just tobramycin by itself. And Tobradex is tobramycin with dexamethasone. Okay, those you can use for eye and ear infections. You have a product that is called Xylate, which is tobramycin with loteprenol. So you have those different preparations of tobramycin that you can see used. Okay. Streptomycin, that's an old drug, but it is still very effective in the management of plague. So, in other words, it works very well against Yersinia pestis, which is the causative agent of plague, especially when you're talking about bubonic plague. Okay. So, streptomycin is used for that. Streptomycin also works in cat bite fever. Streptomycin can also be used to treat tularemia, which is caused by Francisella tularensis. You know, that's why you see tularemia. It can also be used to treat mycobacterial infections, you know, tuberculosis. So it is also used for the treatment of brucellosis. Which is caused by your Brucella species. Talked about the different ones. So that's for your streptomycin. And paromomycin is, like we said, one of the aminoglycosides that you give orally. That's only in this country. In Europe, in Africa, you also have, apart from the oral, you have the parenteral, the injectable paromomycin. And paromomycin, since it's given orally, can help with hepatic coma, you know, and amoebiasis, and it can also be effective in the management of cryptosporidiosis. it also works against some helminthic infections. Particularly against tapeworm. So it is effective there. It is also effective against leishmaniasis. That's another protozoan. Those are protozoal infections. So paromomycin can work in all those situations. Okay. Okay. Let's go up the. Oops. Let's see. Let's take the. So that will be the aminoglycosides. The tetracyclines, which will be the other 30S. The tetracyclines are the ones I've listed here from number 12 all the way to number 23. So from 12 down here all the way to 23. Those are your tetracyclines. Okay. And for the tetracyclines, if we look at the mechanism of action, so they will just interact with 30S. If we take doxycycline as the representative agent, because that's the one that is most often used today, doxycycline. Okay. Number 17. So we have the mechanism of action there, and you will see doxycycline in two basic salts. You have the monohydrate salt, and then you have the hyclate. The hyclate salt. The hyclate is better absorbed and better tolerated, and is also usually cheaper than the monohydrate. Some products that you can see that have the hyclate salt will be the parenteral doxycycline. That's one. You have the hyclate form that is also the hyclate. And Oracia is another preparation. Periostat is another one that would be hyclate preparation. So if it's not a hydrate, then of course it will be a monohydrate. So the ADME for your doxycycline will be just like for your tetracycline hydrochloride. In other words, you can give it PO, you can give doxycycline IV, so it can be administered IV. And if we look at the half-life, the half-life is like 11 to 25 hours. So long-acting. Most of your tetracyclines are long-acting in terms of their half-lives. Plasma protein binding, very high, like 85 to 95%. So it's very high. Distribution, it can get into your peritoneal cavities. It can get into the synovial fluid, so it can be well distributed, you know. And of course, it is not like aminoglycoside, which is highly polar. Tetracycline can get into the cerebrospinal fluid. Okay, so it crosses the blood-brain barrier, so it gets into the cerebrospinal fluid. And that's for doxycycline. Doxycycline is a tetracycline that you don't have to worry about dairy products. Normally, when you say tetracyclines, you think about chelation. Think of the drug being chelated by your dairy products and milk and things like that. No, you can take doxycycline with food, and actually it is even better to take it with food, even including milk and other dairy products. Minocycline is the other one that you don't have to worry about chelation, you know, because they're highly soluble. So if you look at the excretion is primarily fecal. It is mostly excreted through the feces, you know. So, okay. The adverse effects, before we go into the indications, the adverse effects for your doxycycline or tetracyclines, one will be Fanconi syndrome. Fanconi syndrome is a urinary tract defect that you will see in a patient who has ingested outdated and degraded tetracycline. You know, usually when you look at a bottle and you see expiration date, it doesn't matter much. Okay. Even if it's 2 years old, you can still take it, it will still work. The date is there just for the company to protect their rear end. You know, they call it CYA. Cover your behind. But for a tetracycline, it matters. Because if it's outdated, it is usually degraded And if you take it, it can cause that severe renal dysfunction called Fanconi syndrome. So that's one thing that tetracyclines have as the adverse effect. Hepatotoxicity, usually mild, not too severe. Discoloration of the enamel. See, this is another reason why you don't want to use a tetracycline in a very young child. We always say don't use it before the age of 8, because it can still cause that enamel discoloration. And it can sometimes even affect the growth of that child. So that's possible. Phototoxicity, which basically refers to photosensitivity, and that's why you advise the patient that you're giving a tetracycline to not to get exposed to too much sunlight because of the phototoxicity. Pseudotumor cerebri. So that would be like cerebrum in the brain. Cerebrum, okay. Pseudo, which means false. So they can develop a tissue that will look like tumor, but it's false. It's a false tumor that occurs in the brain. Okay. We can look at the GI adverse effects, all these non-specific ones: nausea, vomiting, diarrhea. They can have a furry tongue, a black furry tongue, which just it just sounds and looks bad, but actually it's nothing. Cosmetically it is not acceptable, it is not attractive, but really it's not much. Because pharmacists have now known, or I suppose because we're teaching pharmacists, or to be pharmacists, to always advise the patient on a tetracycline not to lie down within 30 minutes, of taking, especially if they're using a capsule, like your acromycin V or what have you. Because it can affect the esophagus, and cause esophagitis. There are people that will just pop a capsule or tablet in the mouth and go to sleep, and these things are acidic in nature, so they can cause irritation of the esophagus. So you can see those there. If we can move on, let's see, maybe we can do it. Okay. There is a condition that is called diabetes insipidus. Okay. That is when you are excreting a lot of dilute urine. Okay. And that can be seen as an adverse effect of one particular tetracycline, and that's demeclocycline. Okay. Number 15. 1-5, yeah. Okay. Demeclocycline has as its adverse effect diabetes insipidus. If a drug has DI as its adverse effect, that means that the drug can be used for SIADH. So adverse effect for demeclocycline is diabetes insipidus, which will mean that an indication of demeclocycline will be the syndrome of inappropriate antidiuretic hormone. So that'll be one indication. So we're moving now to indications of tetracyclines. There are many other indications of TETs. Okay. You can use a tetracycline for the treatment of acne, and through these indications you can actually derive the antibacterial spectrum of the drug. Okay, so you can use it for acne, aphthous, canker sore. These are sores in the mouth. Okay. So you can use tetracyclines for that. Amoebiasis. Okay. And here again, it would be intestinal amoebiasis. That is caused by that protozoan. You can use it for dientamoeba. Infections. that is a large protozoan that infects the GI. You know, so you can use a tetracycline for that. You can use it for balantidiasis. Balantidiasis coli. That is the biggest, the largest protozoan to ever infect man. And it also resides in the colon. That's why the name is coli. It resides in, in the colon. So, GI related infection. HGE, human granulocytic ehrlichiosis. Human granulocytic ehrlichiosis. You can use a tetracycline for that. It's is an infection that is transmitted also by ticks, just like your Lyme disease. Okay. So you can use a tetracycline for that. You can also use a tetracycline for the management of that brucellosis we talked about earlier. Number 10 would be chlamydial infections. And by chlamydial infections, we are talking about infections caused by chlamydia trachomatis, or ornithosis. Let's put that in another section. That would be better. But chlamydia trachomatis, let's deal with that first. Chlamydia trachomatis can lead to trachoma, which is a very severe infection that can cause blindness, okay, and can cause inclusion conjunctivitis. Inclusion conjunctivitis. And that is not too serious, not as serious as trachoma. Inclusion conjunctivitis will not cause blindness, so it's not that heavy. And lymphogranuloma venereum, LGV, lymphogranuloma venereum, like venereal disease. Okay. So that is a type of non-gonococcal STD. It's not a gonorrhea, but okay. So you can use tetracycline to handle that. Syphilis, that would be another STD that one can use a tetracycline for. You can use a tetracycline for chancroid, and that is caused by Haemophilus ducreyi. I think that's one of the questions on that study guide, causative agent of chancroid. You will see it there. So you can use a tetracycline for that. Of course, for gonorrhea, it is effective in the management of gonorrhea. You can use it for peptic ulcer disease. That's a product that is called Helidac. That contains bismuth and your tetracycline. tetracycline is present in there. You can also see it used in malaria. Okay. Let me write this. Those are the three components of your helidac that you can see used for PUD, that is peptic ulcer disease. That's what it contains. So malaria, for malaria you can use it prophylactically or even for treatment. Normally you will give doxycycline 100 milligrams twice a day. Okay. But for prophylaxis, you can just take one tablet a day, especially if you're traveling to an area where you're likely to come in contact with plasmodium, which can cause that malaria. So anytime I go to Nigeria, I always have, doxycycline tablets with me, because it does help prophylactically. And you can see it used in mycoplasma infections. And that mycoplasma, it can cause pneumonia. So you have mycoplasma pneumoniae, which is classified as an atypical type of pneumonia. So you can see it being used there. Cholera, I don't think we've mentioned cholera. Okay. That's Vibrio cholerae, which you can see been listed in there with is okay. Let's see. Okay, we haven't put there. Rickettsial infections. Rickettsial infections, many of them, typhus, Rocky Mountain spotted fever, South American spotted fever, the jail fever, query fever or Q fever, which is sometimes called the 9-mile fever. So it's in the olden days, they felt like if you just walk 9 miles, the fever will break. And that's why it was called 9-mile fever. It's a type of rickettsial infection. Scrub fever, or scrub fever. Scrub fever, it is also sometimes called scrub typhus. Okay. So you see that typhus is different from typhoid. Typhoid is a salmonella infection, Salmonella typhi. But typhus is a rickettsial infection. Okay. And have bush typhus, which is also a rickettsial infection. Okay. Mycoplasma, chlamydia. Okay. I think we have most of them. Okay. That's syphilis. Topically, seborrhea, can be managed, and that's topical application of one of the tetracyclines. For instance, this drug, methylcycline, is just administered topically, and this is for that. Acne, that's sarecycline, is just used for acne, and I think we've mentioned it up here. Rosacea, that's another indication. Of a tetracycline. So you can use it for a lot of things. Periodontitis. For this one, periodontitis, you are not using the tetracycline as an antibacterial agent. You're just using it to reduce the activity of the enzymes that are breaking down the gums, within the mouth. Okay. So there's a drug called Periostat. This baby. Okay, that's a brand name. Periostat is actually a doxycycline that you use for the management of periodontitis there. Now we've covered most of them. Let's see. Okay. Yeah. We can't leave that area. And the reason I left this drug up here, Flagyl, is because we call it a miscellaneous agent, right? Because it is not a protein synthesis inhibitor, but as you say, it can be used in the amoebiasis. We said it can be used for both intestinal and extraintestinal amoebiasis, and it is also effective in managing rosacea. And we'll talk about it as we go along. Okay. So we can leave the 30S along there and take out this one. Okay. If we go to the 50S agents, if we go to the 50S agents, lincosamides. Examples of lincosamides were the lincomycin, and its chlorinated derivative, which is clindamycin. I don't want to leave the tetracyclines without mentioning traveler's disease. That we can add here. That's important. Traveler's diarrhea. That's what I don't want when I go to Nigeria, so that's why I take doxycycline with me. Okay. We will take clindamycin as the representative agent here. And rub all of this off. Okay. Let me just say something here. There's an STD that people just say chlamydia. You know, they say they have chlamydia. When they say they have chlamydia, they're talking about cervicitis and urethritis. You know. That is caused by this organism, chlamydia. So chlamydia can cause pneumonia, chlamydia can cause STDs like you see. It can also cause ornithosis. So have different conditions that chlamydia can cause. But anyway, when people just say they have chlamydia, they're talking about the cervicitis that chlamydia organism causes. Inflammation of the cervix. Well, okay, let's leave it like that. Finish with the protein synthesis inhibitors, then I'll mention something about flagyl a little later. So if we take clindamycin as the representative agent there, so clindamycin, just like macrolides, will work at the 50S ribosomal subunit. That's the mechanism of action. And clindamycin comes in different preparations that you can see. Our next thing is the preparation of clindamycin. Duac gel is another one. Benzaplane. That's a preparation of benzamycin, benzoyl peroxide, and clindamycin. those are some preparations. Okay. You can also see clindamycin in the gel form and in the solution form that can be used, topically. And there's a cream preparation of clindamycin. And there's an oval preparation, which is a vaginal preparation that you use just like a vaginal insert, and you have plagets, clindamycin plagets that you can just use to rub externally. So you have all those different preparations. You have akanya, which is also a preparation of clindamycin. Okay. And then you have clindamycin with tretinoin. That is clinda plus tretinoin. Those other four are a little different because those are basically, all these four contain essentially the same thing, which is benzoyl peroxide with clindamycin. Okay. So it has different preparations like that, and of course it has the oral preparation that one can use, and then the possible injection. Okay, so we know the mechanism of action, and we've seen the different preparations of clindamycin, and it can be used for many different things based on its antibacterial spectrum. We know that it is effective against anaerobes, and it is very similar to erythromycin, except that it works more or better on anaerobes than erythromycin does. Okay. So if you're thinking about treating anaerobic infections, Flagyl and clindamycin should always come to mind first. Flagyl and clindamycin for treating anaerobic infections. And then after that, you can go to cefamycins, then you can go to imipenem, carbapenem, and then of course you can go to those combinations, that is a penicillin in combination with a penicillinase inhibitor, like sulbactam, like zosine, all those are good for anaerobic infections. But the first two that should come to mind will be clindamycin and Flagyl. Okay. So for clindamycin indications, we know you can use it for the treatment of PCP, okay, pneumocystis, carinary pneumonia. And if you use it for that, it should be given in combination with Primaquine. That's the best regimen if you are using clindamycin for PCP. So, clindamycin with Primaquine. Okay. And if you have impetigo, clindamycin can also help. Okay. And if you have babesiosis, which is caused by Babesia crofti, one can use clindamycin, and you can use it in combination with quinine. So for babesiosis, it will be clindamycin with quinine. You can use it also, or it works also in vaginal, let's say bacterial vaginosis. Okay. Bacterial vaginosis. Flagyl actually works better than clindamycin in bacterial vaginosis. Because in bacterial vaginosis, you usually see a lot of anaerobic organisms. That's why we said if you have an anaerobic infection, Flagyl and clindamycin should come to mind. There's an analog of Flagyl that is also works in your bacterial vaginosis. Celosec is its brand name, SELOSEC. Celosec works very well in bacterial vaginosis. If you have abscess, okay, be it pelvic abscess or lung abscess, anytime you have an abscess, it's usually an anaerobic environment. And so one would want to use, clindamycin in such a situation. Lemierre's disease. Lemierre's disease is an infection that is caused by an anaerobe. It is caused by, your Bacteroides, and it's caused by Fusobacterium. Okay. And that can be a deadly condition that affects the veins, like the jugular veins and all that, and it can lead to death, Lemierre's disease. And you can use clindamycin in such a situation. The melanogenicus infection. And as you can see from the name of the organism, melanin, so it's a skin infection that is caused by that anaerobe bacteroides, bacteroides melanogenicus. And what it really causes is a type of cellulitis, a form of cellulitis. And you can use clindamycin in that situation also. It is also very effective in the management of pneumonia, apart from just PCP, or bacteremia, or even meningitis that is caused by anaerobic organisms. So we can see it used in those situations. Let's rub this up. Okay. And then in toxoplasmosis, you can use clindamycin. This is an organism that causes a lot of blindness in AIDS patients, Toxoplasma gondii. Causes blindness in AIDS patients, and regular people, even if you don't have HIV/AIDS, but you don't clean out the the bedding of your cat. If you have a cat at home and you're not sanitary with the beddings of that cat, you can actually pick up toxoplasmosis from the bedding. And for that, one can use clindamycin in combination with pyrimethamine. And you notice that those three are actually drugs that you use also for malaria. Okay. See, toxoplasmosis, we said clindamycin with pyrimethamine. Your babesiosis, pyrimethamine with quinine, which is also an anti-malaria drug. And then PCP, clindamycin with primaquine, and primaquine is also an anti-malaria drug. So see those three in combination there. Okay. And then lastly, we can put number 10 there, which is acne. So you can say that clindamycin works against your acnes, Propionibacterium acnes. So those are the indications and adverse effects with clindamycin. The adverse effects are limited to about 3 areas of the body. The skin, that's 1. The bone marrow, that's 2. And then the GI, that's 3. Okay. On the GI, you can get a lot of your non-specific adverse effects, but particularly diarrhea. Clindamycin can cause a lot of diarrhea, even though you can use it to manage diarrhea if that's an anaerobic organism involved. But anyway, regular diarrhea, and then your CDAD, Clostridium difficile associated diarrhea, yeah, it can produce that. Pseudomembranous colitis, it can also produce that. So diarrhea is a major adverse effect. Then 2, on the skin, you can get just your regular rash, but it can also produce SJS. It can cause SJS, and it can also cause TEN. Toxic epidermal necrolysis. Toxic epidermal necrolysis, and that's probably the worst type of skin reaction you can get from a drug. So it produces that. I mean, your other things can be present, rash, itching, and stuff like that. So that's on the skin. And then on the bone marrow, it can produce bone marrow depression. So you can get thrombocytopenia. It can cause thrombocytopenia. It can also cause granulocytopenia. So that's another effect on the bone marrow. Okay. So those are really the standout adverse effects of your clindamycin. Okay. That would be the lymphocytes right there. For the macrolides, you're talking about the erythromycin group. So erythromycin, zithromycin, difficile, and biaxin. Those are the macrolides. And the one that is most often used today, of course, is Zithromax or azithromycin. So for the macrolides, we know the mechanism of action will be interaction with 50S ribosomal subunit. That's how it will work to inhibit protein synthesis. And just quickly to say something about deficit from the name, it is mainly used for recurrent Clostridium difficile infections. So you're talking about CDAD, you're talking about pseudomembranous colitis. So that's what that one will be used for. There's a drug called Simplava. It is a monoclonal antibody that you use for recurring Clostridium difficile infections. So if you're getting CDAD in a repeated manner, or Clostridial outgrowth, you can use Simplava. Simplava is not a macrolide. It is a monoclonal antibody that you use for repeated occurrence of Clostridial infection, particularly CDAD. Okay. So, anything else to take out there? The usage of Biaxin has really gone down, but a major difference in terms of uses between Biaxin and Zithromax is that Biaxin is very effective in PUD. You can use it in combination with other agents for the management of peptic ulcer disease. Okay, so taking Zithromax as the example there, we have the mechanism of action there. And Zithromax, of course, is administered orally. You have your Z-Pack that everybody knows about, and you have your Tri-Pack. Okay. And the Z-Pack, 250, and you take 2 at once, and then 1. Has the 250 milligrams Zithromax. So, and the Tri-Pack is 3. You take 1 a day for 3 days, and it contains 500 milligrams. So you have that, and then you have azazite, which is Zithromax or azithromycin that you use in the eye. Okay. Usually for inclusion conjunctivitis, or to prevent blindness caused by chlamydia trachomatis. Okay. So it has those preparations and those routes of administration. Okay, if we can quickly look at its adverse effects. Its adverse effects are minimal because your macrolides are actually very, very safe drugs. One of the safest classes of antibiotics. So you can just have things like GI. That's the number one adverse effect of your macrolides, is the irritation, or what you call epigastric distress. epigastric distress. That's the number one adverse effect. In fact, this, well, erythromycin is a macrolide, and it has what you call a motilin effect. That is, it increases peristalsis, you know, and that's why you see that GI adverse effect with erythromycin, but you also see epigastric distress with your Zithromax. Very minor hepatic disorder, hepatotoxicity. Doesn't occur that often, but it is possible. Okay. And also a minor auditory adverse effect. You see that with macrolides in general. Very low in occurrence. You know. So by and large, that's it. You know, the macrolides are very safe agents. And then we can look at the indications, and this time we'll focus on your Zithromax. Upper and lower respiratory tract infections. Upper and lower respiratory tract infections. And when we're saying upper, we're referring to things like, say, sinusitis. Tonsillitis, otitis media, so pharyngitis, this would be some examples of upper respiratory tract infections. So upper and lower respiratory tract. If it's the upper respiratory tract infection, usually it is the Z-Pack you will see prescribed. You know, if it's lower, and there we are talking about, say, like COPD, for instance, like pneumonia, those are lower. Bronchitis, bronchiolitis, so those will be lower respiratory tract infections. In that situation, you can see the tri-pack, you know, being prescribed. Okay. Babesiosis. already talked about that. Can be an indication for your macrolides, in particular your Zipromax. Okay, so that will be another indication. Gonococcal infections, so gonorrhea. We used to have a preparation that was called Z-Max, and Z-Max it contained 1 gram of granules of Zipromax granules, and the patient would just have to use that 1 pack of 1 gram just once for, say, things like gonorrhea, chancroid, caused by Haemophilus ducreyi. So you can see Zipromax used for that. Non-gonococcal infections. Urethritis, non-gonococcal urethritis, or non-gonococcal cervicitis. Okay. So by that, we mean things like STDs or urethritis or cervicitis that is due to things like chlamydia and that mycoplasma, or urea plasma. Urea plasma, urea liticum. Yeah. So gonococcal and non-gonococcal infections caused by these agents. You can use your Zipromax to manage such conditions. Mycobacterial infections. Mycobacterial avium intracellulare complex. Okay, so we mentioned that under aminoglycosides. So yeah, you can use your Zipromax to manage such conditions also. Okay. In just 2 minutes, let me just quickly say this. Chloromethylins, you basically have 2 of them that are used clinically. Altabax, let's see if I put it here, okay. With the pamulin, that's Altabax, and then lefamulin. Lefamulin is used for pneumonia type conditions, bacterial pneumonia, you know, and ribtapanilin is basically used for impetigo. That's what you use ribtapanilin for. So that's all there is to that one. And if you're thinking about the mechanism of action of ribtapanilin, it would interact with this LP3 protein that is in the vicinity of that is like a subset of your ribosomal, 50S ribosomal subunit. And so it would inhibit protein synthesis by inhibiting the transferase, that is inhibiting the transfer of these amino acids. But anyway, it inhibits protein synthesis by interacting with LP3 proteins, which is related to 50S ribosomal subunit. And it's used for, it's used for the management of impetigo. The other agent that is used for impetigo, of course, is mupirocin that we have down here, number 36. Mupirocin, which will inhibit your isoleucine transferase. It will inhibit isoleucine transferase, so you can get an inhibition of protein synthesis that way. And mupirocin, of course, is administered topically on the skin, and it can also be administered in the nose. You just apply it inside the nose, intranasally. And it has very, very minimal adverse effects, just some itching and some stinging. It can give you a stinging feeling inside the nose when you put it in there, and like I said, it may cause a little rash. So if you have impetigo and you want to manage it systemically, not by topical, like Altobax and mupirocin, you would have to use something like one of your PRPs, penicillinase resistant penicillins, or you can use erythromycin, or you can use clindamycin, or you can use Keflex, cephalexin. So penicillinase resistant penicillin, erythromycin, clindamycin, and cephalexin or Keflex. So you can use those systemically to manage your impetigo. So that's what we want to quickly say about those. Oxazolidinons, you have just two: linezolid, right there, number 33, and tedizolid. Okay, and linezolid will be the representative agent there. It just gives you a bactericidal effect on Streptococcus, but it gives you a bacteriostatic effect on Staphylococcus. So Streptococcus, it is cidal. Staphylococcus, it is static. It is also static against Enterococcus. Okay. And it is essentially used for VRE, it works against vancomycin-resistant enterococcal infections. It also works against VISA, that is vancomycin intermediate, VISA, intermediate staphylococcus infections. And it also works against MRSA, you know. And you can, of course, use it also for penicillin susceptible streptococcus pneumonia infection, PSSP. Okay, so it is used for VRE, it is used for pneumonia, either community acquired or nosocomial infections, you know, caused by your strep and staph. And it can also be used for skin infections. You know, you can use it for uncomplicated triple SI, SSSI, okay, or complicated SSSI. For uncomplicated skin infections, you just use the low dose, 400 milligrams, you know, and that can be given PO or IV, you know, but for uncomplicated infections, it's good enough to use it orally, 400 milligrams PO/BID. But for complicated skin infections, and there you're talking about either MRSA or MSSA or, you know, group A beta hemolytic strep or A galactiae. So all of those, you will use 600 milligrams IV, and that will be Q12 or twice a day for that. So VRE, you know, pneumonia and skin infections. And we know the drug has an MAO inhibitor properties. So you don't eat certain types of cheese or drink certain types of wine in that situation. So we can inhibit MAO. And it can also give you hypoglycemia, and that's a very, very bad effect of that drug. What's the most serious effect that metformin can give you? Lactic acidosis. You can see lactic acidosis with linezolid. And you don't want to give it to a patient that has PKU, phenylketonuria, because it will worsen that particular condition. So those are some cautionary things. And in terms of major adverse effects, they are all related to the GI and the bone marrow. It produces a lot of bone marrow depression, and it also causes nausea, vomiting, diarrhea, and headaches. Yeah, so I think we'll hold it there. We didn't get to mention flagyl, but that's okay. All right. Questions? Who's the class rep?
I'll be.
Very good. I was waiting for you to raise your hand. I knew you were going to be. Miss Hill, what happened? Huh?
Still in my situation right now.
Ah.
Mm-hmm.